This conference will now be recorded.
Thank you. Good morning, everyone. I'm Keisha Jackson, and I'm the owner and administrator of Humanity Hospice. And Tom, introduce yourself.
Hello, everybody. I'm Tom Bishop Miller, and I am the marketing or director of business development for Humanity Hospice.
So today we're going to talk about the collaboration of hospice and long-term care. What our objectives are going to be. We're going to define hospice and the scope of care. We're also going to talk about the general criteria to determine hospice eligibility. We're going to differentiate between the responsibilities of the hospice and the responsibilities of the long-term care facility. We're going to know how to formulate a collaborative and coordinated plan of care for both agencies. So the definition of hospice care, I'm going first, Tom. We're also going to talk about advanced directives and do not resuscitates and how they play a role in hospice and in long-term care. Sorry, I'm cleaning my spot up. Okay. Residents are entitled to hospice services per both state and federal regulations. Anytime a patient qualifies for hospice benefit, it is never anyone's job to take it away from them. It's a benefit they've paid into, and so they have to be offered that in your facilities. Regulations established that the long-term care facility is the resident's home. So that's why we're able to come into long-term care, assisted livings, because that's the place where they live. Back when hospice first started, it was a home-based service. So you went to their homes, and it was a volunteer. How hospice started was a volunteer basis, and now it's obviously become a healthcare industry. Anyway, so hospice offers the patient a caregiver system and the family program. So everything that we offer, hospice is not just for the patient, it's for the patient and family as a unit. So hospice is intended to meet the physical, emotional, and spiritual needs of the patient. So if you think about it, a lot of places are just geared toward, fixing that issue, COPD, or especially in the healthcare industry. But with the hospice side of it, we take care of all of their clinical needs versus their emotional and spiritual needs as well. So we are required to have social workers on staff, chaplains on staff, nurses on staff, aides on staff, a doctor as a contract staff member to take care of all of those needs. Resident electing, a lot of times people have a misconception of when you elect hospice benefit that you're giving up. And that's not actually true. It's more about quality of life versus quantity. So hospice isn't going to do anything to speed up the progression of their death, but they're not going to do anything either to prolong life. So we're going to meet the patients where they are, and we are going to let that disease follow its normal course. And if the patient has a terminal diagnosis, if that disease follows its normal course, the patient should have a life expectancy of 6 months or less. When residents, another misconception is when hospice takes over a patient's care or a patient is signed on to hospice, the hospice, sometimes the facility or the patient's families and the patient feel like that they will get less care from the facility because we're coming in providing that care, and that's actually not true. They get more care. They still get the care that you're providing in the long-term care or the assisted living. They just get extra care from the hospice side. The nursing home patient receives the benefit of, I just said that. Okay, so the challenging part is that we need to collaborate and communicate. We need to cooperate with each other and always have the patient's best interest in heart, number one. Number two, we need to understand why we can't do certain things on both sides. So we need to understand to be able to communicate our regulations. We know some of your regulations in long-term care and assisted living, but we look for you guys to teach them to us, and then we'll teach you ours. So we can say, oh no, we can't do this, and no, we can't do this in this facility because of these regulations, or we can't do that in this hospice because of these regulations. So as long as there's great communication with your hospice provider, they shouldn't be doing anything to get you in trouble, and we shouldn't be doing anything to get us in trouble. So y'all shouldn't be doing so. As long as you can keep the patient number one, and then care plan everything. Just care plan. So that's the biggest thing. There are lots of things, a lot of regulations that we can get around based on care planning. So you just got to work with each other to make sure that you're covering all of those regulations, and we're not doing anything or ordering medicine or equipment that's going to get you guys in trouble for your facility. So that communication is really, really important. And then when we come together with a contract, hospices are required to have a contract to provide care into a nursing home, but they're not required to have a contract in assisted living. Assisted living sometimes have their own contract that they want to use, but we're not required to have one. So in that contract, it should be really clear what we're responsible for, what you're responsible for. So when a hospice provider brings you a contract, it should say what everything that we're required to do based on our regulations, and then hopefully we've matched that with your regulations. Okay. Okay, so hospice, the scope of hospice, we offer lots of different care. So skilled nursing, a medical social worker, personal care, meaning either aide or a homemaker, spiritual care, volunteer support, bereavement support, and physician services. So all of those services are offered to every single hospice patient. They're required. That's part of our regulations. And not only to the hospice patient, but also to that family. So we continue to follow that family. Hospices are required to follow the family for bereavement services for at least 12 months after the patient has passed. So that's pretty different than long-term care. When a patient passes, that's kind of it for you guys. If they come back, or if you have another program put in place to follow up with them, but most generally, that's pretty much the end of contact unless the patient's family contacts the facility for anything. But hospice, we contact that family throughout, 12 to 13 months on service. We do lots of different things. A lot of hospices do lots of things, but that's something that we do. By selecting hospice services, he's asked to focus on palliative care. So I think that's probably some of the hardest and unclear expectations for hospice. A lot of times patients had a huge decline, and then the nursing home will refer them to hospice, telling the patient that, well, you're just going to get extra care. And then we get there and know you have a terminal diagnosis, so hospice doesn't really sugarcoat that. We are pretty clear about what you're on service for. You're here because you have a terminal diagnosis, and we're not going to seek aggressive treatment. We're not going to go back and forth to the hospital. We're not going to do a bunch of IVs. We're not going to do a bunch of blood transfusions. All of those, that's not necessarily palliative. So palliative is just to let that disease run its normal course, and then to maintain their level of comfort if we can. So that's what hospice is about. We're about, maintaining that comfort, which is sometimes makes nursing homes and assisted livings uncomfortable, especially if using end-of-life medications that they might not have used before. Morphine, Roxanol, those kind of things where, you'll use them, but we use them a lot. So that education piece, I think, is really important to have your hospice provider come in and provide that education to your med aides and to your nurses that are giving those medications, And even we can, some hospices have access to a pharmacist that will come and talk with your group as well and give you, because some people are very nervous about giving those medications. So, but once there's education provided, hopefully they'll eliminate the worry about those end-of-life medications. If the hospice provider shouldn't be giving the pain medication or the end-of-life medications so much that it's going to, hasten, hurry up, and yeah, that's not what we're about. Euthanasia is still against the law in Oklahoma, so we don't. Our assisted death, we don't. It's against the law in Oklahoma still. Go to Michigan, I believe, for that, or somewhere.
So the other thing too is, as far as regulations go, certain things that a resident does will require you all to send them out to the hospital. Like if they are declining or having issues, you have to send them out because that's the next level of care that you guys can't provide. So by having hospice involved, it eliminates that for you guys on the long-term care side, where hospice acts kind of as that higher level of care where you don't have to send the patient out to the hospital, because we're able to kind of manage those symptoms a little differently with meds and different things like that. So that's the benefit to the patient and the facility to have hospice involved, is they don't have to go to the hospital. I just talked to a DON yesterday. Patient went out, thought had COVID, had 105 temperature. The hospital sent him right back, rolled through the door with 104 temperature, and she had to send him right back out. So that was 2 hospitalizations in less than, just a few minutes. So.
All right, so we are paying attention, obviously, to end-of-life issues, pain management, one-on-one emotional support, and then have a financial relief due to hospice paying for medication. So when a patient does sign on to hospice, the hospice is required to pay for any and all medications related to their terminal diagnosis and any and all equipment and supplies related to that terminal diagnosis. So that does sometimes ease the family of not having to pay for those medications and diapers and wipes and gloves and pads and all of those kind of things that are potentially related. Hospital bed. They might have Medicare, but they have all these co-pays, or they might have Medicaid, they have co-pays. So it definitely takes some burden off of that family to where they can focus on other things, hopefully. We have hospice is required to have volunteer services. So we are required to have volunteers that do things that save the hospice money. So Medicare requires that because when hospice first was originated, it was on a volunteer basis. So they still wanted to keep that component of volunteerism. So we are required to have 5% volunteer hours per patient care hours. So our total patient care hours, 5% of that has to be volunteer. And the volunteer can do many things. Volunteer can come in and file in the office to save money for an office person. They can assemble things. If we have a marketing event or something, they can assemble things for that. They can see patients. They can actually go and visit with patients and provide that caregiver relief. Let's say the wife wants to go get a haircut and the husband can't be left alone. So we might have a volunteer go and sit. They'll be trained on how to care for that patient. They'll be trained on what to do in an emergency. So, but we have to have those kind of volunteers as part of our regulations. So, how that translates for you guys is we will have volunteers come into your facilities, and it might be pet therapy. We have a lot of hospices will have pet therapy, and so they might bring in an animal to your facility to provide some comfort to the hospice patients there, to your residents there. And luckily, if they're coming there to see the hospice patient, they'll get to see a lot of your staff and a lot of your patients there. So it does definitely brighten people's day when they have, especially if they're a pet lover and they don't get to bring their pet to the long-term care facility. So that's always good to have. So eligibility, we have to have 2 doctors say that a person is terminal and requires hospice services. They have to be diagnosed with a terminal diagnosis for 6, and they have to have a life expectancy of 6 months or less to live if that disease follows its normal course. So, so let's say that the long-term care facility, the nurse send us a referral. We would come out and call the doctor, get an order, come out and evaluate that patient, see if that patient qualified, do an assessment, and then we would take that back to what we call an interdisciplinary team, or you'll hear the term from hospice, they'll say interdisciplinary team, they'll say IDG or IDT. Every 2 weeks, we're required to have those with our whole entire discipline and talk about what's going on with that patient for the last 2 weeks or what's coming up for that patient. It might be a research, it might be some problems going into a different level of care. So also, they have to be seeking palliative care over curative care. Do you know how if people want to ask questions, how that works here?
You just ask them.
Okay.
They can unmute themselves.
Yeah, they can hear everything and they
Okay.
unmute themselves and ask a question.
Okay, perfect. So yeah, feel free if anybody needs to ask any questions or have anything you want to add to this conversation. It's very informal. We've been doing this with you guys for several years. Yeah. So it's very informal. If you have any questions, please feel free. And what time do y'all break? 11:30, whatever. Hold on, let me look.
So the other thing I always like to put, the way we have our thing set up is our marketing team goes out and visits with the patient and the family, and we explain this benefit to them so that they understand it is a Medicare benefit to them. And this is like Keisha had said, this is what they pay into. But people get a little freaked out when you start saying they're going to die in 6 months a lot of times. And so we try to be very honest with them, but also help them to understand that this is a hypothesis. Like this is an educated guess. If Medicare has us break things down into certification periods, and so if they're still alive at 6 months, we still have to verify with our interdisciplinary team that they still qualify for hospice, and they can be on hospice, for a year or two. It just depends. We have to make sure that we are doing our assessments correctly. We're communicating with the facility and making sure that this patient truly still qualifies. If they don't qualify and we have to discharge them, maybe they've gotten better. We see it happen sometimes. They get better and we discharge. It doesn't mean that they can't come back onto hospice. This is a lifetime benefit, so it can start and stop. I mean, we have certain rules that we have to follow on our side, but it doesn't ever end completely. So that's kind of a nice thing. We always tell them you're not stuck with this. You have the right to stop. And
Medicare directly? Or do you
Oklahoma is one of 2 states, which is very sad, but we are one of 2 states that does not have a Medicaid benefit for hospice. They've done a couple of things where they have, if they have Medicaid advantage in a home setting, not long-term care, because you can't have that long-term care. But if they're in a home setting, then we're an advantage provider. So if somebody has Medicaid and not Medicare, and they're in a home setting, then they do have hospice services covered. So, but if you just have a straight Medicaid patient, which happens all the time in long-term care, you'll take patients like Medicaid pending, so they don't have any money, they've never worked, they don't have Medicaid or Medicare, but Medicaid will pay you room and board for that patient. That patient doesn't have a hospice benefit. So those patients would be what we call charitable. So hospice would come in and take care of those patients for free. And we would get Medicaid, would pay for their meds. We would just provide the nursing, the social worker, the chaplain, and then obviously we would provide DME and supplies. We just work with our vendors to give us price breaks on indigent patients so we can take those. Most hospices don't take free patients or don't want to take free patients. So you'll just have to speak with your providers about that. If they won't take your free patients, look for another provider because those patients need care too. Not every hospice can take all of them. Obviously, we can't just take free patients all the time, but the hospice providers should do a great job of contract negotiation where they get some price breaks for those indigent patients. Okay. Okay, so in hospice, we talk about eligibility. they're called LCDs, local coverage determination, and that is what Medicare puts out that says, hey, if this patient meets all those criteria, they qualify for hospice. And they have, it's vague, it's the government, so they don't just give you the answers, they make you guess, make you jump through hoops. So they say, well, this looks like what a patient should fit into, but they don't have to. They can have these other things. So they give you basically a very vague template to go by, right, for determination. And not every patient checks every box because every disease is different in every human. So that's why it's vague like it is. But we have these, and we research these patients. We're going to talk about that too. These current guidelines include lung, heart, kidney failure, HIV, stroke and coma, dementia, liver failure, ALS, lung, all the cancers. And then right here is a place you can look up what those are if you have any questions. And they've really grouped, these are specifically grouped into different categories, but they've actually grouped them a little bit differently now. This slide is pretty old, but they've grouped them a little differently where they don't have like a dementia one and an ALS one. They don't have that. They've just grouped all that together for neurological disease. They've also grouped, so you can see there where they have lung and heart separated. They've also grouped together cardiopulmonary now. So they have found over the years that if they have one, they typically have the other. So they kind of grouped those things together now for us. The hardest one for us to get a patient to qualify, honestly, is kidney disease and kidney failure. The criteria is so stringent for a patient to be on kidney disease. And I believe, my own opinion, but I believe that they do that because Medicare also offers an end-stage renal benefit. So I think that they are trying to make that, is everything okay?
Hearing something that's on my screen. I thought maybe it was in here, but it's just my screen.
Okay.
I don't know what's going on. I hear someone talking in the back. Sorry.
Okay, all right, sounds good. So I think that's why they make it so hard for hospice. The patient has to stop dialysis and their creatinine and everything has to be, they almost have to be dead. It's pretty strenuous to get somebody to qualify on this. Most people that stop dialysis last a week, maybe if they're truly on because their kidneys are just gone, then that disease is the hardest one for us to qualify.
It's going to affect their lungs potentially and their heart. So everything can be related back to it. So it's this vicious cycle of, well, secondary to end-stage renal or whatever. So it's frustrating.
Yeah, and just the lab values that we have to have, patients have to be really, really, really sick to qualify for kidney on hospice. So, okay, core services that have to be provided, and that's the services we've already talked about. Dietary counseling, they let the RN case managers do that. If they're trained, all the RNs have had nutrition class and have been taught how, proper diets for patients. So all of those services are required by every hospice company. So this is not just, our company. The collaboration with both, we're going to say that a million times. Collaboration is essential. Hospice providers' care has to be available to the patient 24 hours a day. So just because we only see the patient maybe once a week or twice a week or 5 times a week, we still are required to be available for that family and that patient for 24 hours a day, 7 days a week. So interdisciplinary team, we talked about that. Patients and families are invited to those if they would like to come. And also, obviously, all the staff.
I think in facilities, they call it care plan meeting. And so a lot of times our staff will go and go with the care plan meeting. And the facilities will invite families to come to that, which is a nice time for them to see the facility staff and the hospice staff. And so sometimes we'll have the aide come, the nurse, Sometimes the marketer will even sit in on it. It just kind of depends on the facility. But it's a great time for everybody to really have a good conversation about this resident and where they're at and what their needs are, make sure that we're providing the needs and we have, this conversation in person where it's not text or whatever that could be misconstrued or, so it's beneficial, I think. And so some places we've seen do it better than others, and it works good if that's how you can set it up.
His own care plan as well.
Mhm. Yeah, we're required to complete a comprehensive care plan within 48 hours of admission. So, and that is coordinating with the long-term care facility and looking at their care plan and adding those things to our care plan. One of the things that should be added into all hospice care plans that patients that live in long-term care is a care plan problem that says coordinate all care with long-term care facilities. And if it isn't added in there, it needs to be in the hospice side too. So that care plan should be provided to you guys, soon after admission, and then every 14 days there's care plan updates. So IDT, that happens in IDT. So all those IDT notes should come to you guys. If you're not getting them, they're part of the patient's record, and we bring them out to the facility as soon as they get finished and printed. And they're like 37 pages each.
You know, there's the MDS stuff.
Do we give them to the MDS? Is that what you said?
You have like your own little MDS people and stuff.
No, hospice, we don't do an MDS. We do what we call HIS, which is similar to that, but it's not anything compared to what you guys have to do. So, or home health has to do. It's pretty basic. All right, so long-term care facility is required to provide daily care with all the patients. So just because we start the patient doesn't mean the patient should lay in the bed until we get there. And that happens a lot. I say that, as kindly as I can, but a lot of times they will skip getting a hospice patient up or change a hospice patient because they know the hospice is coming. And so they'll wait for that. And that really aggravates patients and families, because once they start on hospice, the aides are like, well, hospice is coming. And so that's something that we need for you guys to help us with. And yeah, but she might not come until 3 o'clock in the afternoon or noon or whatever. So patients still get the same level of care that they were getting before at your facility, and then we just add to that care. And so the hospice is good. The RA coordinates the care plans, makes intermittent visits, educates families and staff. That's some of the other things that I think can sometimes be hard is to be a patient advocate. Sometimes we ruffle feathers, and sometimes y'all ruffle feathers. So I think that instead of that, like if there is an issue, like I just mentioned, for instance, about like the long-term care facility is just not taking care of the patient because now they're on hospice, the patient never gets changed. We're there, they've got rings all around them. So we're going to come to the director of nursing or the charge nurse every time and talk to them about what can we do to fix this situation. But what ends up happening is there ends up being like a lot of finger pointing, well, the hospice was supposed to be here, or, the hospice, that's their responsibility. Or it can be the other way where the hospice is calling and telling the family that, every time I'm there, she's soaking wet. Can you help us with this? We talk to all the staff. They really should come to you first and try to solve that problem for that patient without getting the family upset at either one of us, because we are there together to take care of that patient. So hopefully your hospice won't go around you, and you lay clear guidelines on how that is. But know that if the patient continues to be like that, the hospice is required to be a patient advocate first. So they're going to go around you. So they're going to do it if it continues. So they have to be a patient advocate first. And sometimes that's very, very hard for facilities because they get really frustrated at the hospice. And so just, hopefully you have a great relationship with your hospice, or you build a great relationship with your hospice, and you will be able to combat those problems before they get the family involved, or before the family will call the hospice and say, well, every time I'm here, she's wet. What can I do? Like, we always our company always refers them back to the nursing facility at the, we we don't work there. So you're going to have to talk with the facility, and we'd be happy to be there with you if you need us to, but we try and always have them come back to the facility to talk. Collaborative relationship, we maintain communication, with the care plan. If there's going to be a care plan change, we need to communicate that. And if there's care plan change on your end, it needs to be communicated on our side. So the responsibility for the physician services, the attending physician and the long-term care medical director will continue to follow regular visitation schedules. So that just because they signed on to hospice doesn't mean that they don't get to still see their doctor or their nurse practitioner that might be in your building. That can still continue to do that. The only difference would be that the medical director is just a resource for the hospital, for you guys as well, to help with palliative care. So, we need to, if your doctor orders something, we're going to take it to our medical director to see if it is palliative or not. And then we're going to have that conversation and see if it is something that is covered or if it is something that's going to benefit the patient. A lot of times, especially in long-term care, your regulations are that you can't have those PRNs on, those big, Schedule II narcotic PRNs, can't have those on for a long length of time. Well, that really contraindicates what hospice does. So there's a lot of time the pharmacist will come in and do a pharmacy review in your building and recommend all of these meds to be DC. This happens daily in hospice, daily. So the doctor will just go through and sign all of those and not pay attention that it was a hospice patient. And then now we have to reorder all of it. So it's just a waste of Medicare money because you've destroyed all the medicine now. So it's just so that kind of thing happens a lot. So we just have to, we put PRN medications in place for the patient in case there's an emergency. And so we're always trying to do things that will, that's in the patient's best interest. So if your nurse calls us at 3 o'clock in the morning and the patient has severe anxiety or having an anxiety attack, and you've already DC'd my Ativan that the patient hasn't used in 30 days, now the patient, I've got to come see the patient. So that's going to take me, 20, 30 minutes, an hour, wherever they are. I don't know. I'm going to have to go see the patient. Now I'm going to have to call the doctor at 4 o'clock in the morning. I'm going to have to get an e-script sent over, and I'm going to have to get that med delivered. So that patient now has almost 2 hours, and the pharmacy has 2 hours to deliver a stat medicine. So we're talking almost 3 hours that this patient has suffered, in my mind, suffered with anxiety, causing all kinds of havoc in your building. Anxiety or agitation, when in turn I had medicine there, but it just got DC'd. So that's something that I think needs to be worked on in long-term care and in hospice side, because it happens every single day in hospice. And it's nobody's fault. That's just your regulations. If they haven't been used, they have to be DC'd. So, and it does say excluding hospice, but it never happens like that. The pharmacy just automatically sends all those recommendations, and then they're all DC'd. So it's just a vicious cycle of doing what's best for the patient and staying within your guidelines. All right. This is so repetitive. I didn't make this slideshow, but it's good information, but it's pretty repetitive. So how does the admission process work? So anyone can refer a patient to hospice. It can be a friend, a family, it can be a nurse, it can be anyone, administrator, it can be anyone. So long-term care are most sensitive to the readiness of hospice acceptance. So in your building, you're required for your regulations, and so are we. We're required to offer you an in-service over what hospice provides. So if you're the administrator of a long-term care or a assisted living, get the hospice to do that for you. There's no better person to do it than the hospice to tell you what all we provide. So that'll check that off your list that you provide that education for your staff.
And even for yourself, I mean, if you're new to being an administrator, it would benefit you to call on a hospice to come in and really go over this, you know, with an hour-long in-service or whatever you have time for. We could do it in 30 minutes, but plus then you get to hear what your staff has heard, you know, and so there's lots of, well, that's not what I heard, or that's not what I always knew about hospice or whatever. That way everybody's on the same playing field. And like I said, if you're new to being an administrator, then you have that from the horse's mouth.
Okay. And so again, we talked about that it's the patient's right. I've been in hospice for almost 21 or 22 years, long time. And I've run across so many different scenarios. So I can tell you of a scenario specifically in Oklahoma. There's a couple of buildings that will not allow hospice in their building, which is not legal. It's not. It's against the patient's rights, and it is illegal, but they've been doing it for 20 years. So all of those patients in that facility do not get hospice care. They just don't. So it's very strange to me how that's allowed. It is never allowed. I don't know how they get away with it. What they tell the families are, well, if you want hospice, you have to move. So, and according to their owners and administrators, they had some bad experiences, got them some deficiencies, because the hospice can get you a deficiency if they aren't doing what they're supposed to do and y'all aren't communicating. You know, if the aide's walking down the hall in gloves, there you go, infection control deficiency. So we do everything we can do to teach our staff what to do to not get you a deficiency. But if your regulations change, your regulations are like this big, ours are like this. So we are not going to know all of your regulations. So we definitely, that communication and collaboration is so, so important. And then I would encourage every time you have a new provider come into your facility, for you to have that staff come in and do an in-service at your facility. You in-service them on what your expectations are and what your regulations are. Some facilities have different things they like done, and the hospice should be able to comply with those things. So if you have a brand new hospice come in your building, then you need to bring them in and make sure they are on the same page as the other hospices and everybody's doing the same thing. So part of long-term care staff, part of your job is to recognize when a patient needs outside services. If they need therapy, if they need hospice, if they need wound care, whatever it might be, if they need those kind of things, it's your job to make sure that they get those kind of things. So you review the legal paperwork, you identify the legal representative who can make decisions. And actually, a patient now does not have to have a legal appointed representative to elect hospice services. It can be a family, it can be a friend. They don't have to actually have like the legal representation. That law changed, several years ago. Yeah. So you obtain an order, a physician's order for hospice evaluation and a potential admission. You know, I'll have people say this to me all the time. Well, could you just come look at the chart and see if they qualify? No, I cannot look at the chart. That's illegal. Please don't let your hospice come in and just ransack your charts. That's not allowed. They have to have patient consent to look at the records. We have to have a physician's order to touch a patient. I can come out all day long and sit with your family and the patient and talk to them, but I can actually lay hands on that patient without a physician's order. So I can tell them what hospice does. I can introduce our services to them, but I can't actually look at the patient's record, and I can't actually look at the patient's, touch the patient without a physician's order and the patient's consent. So just know that. Don't ask us to come do that. We're not gonna. Now we will talk it through with you. So say your DON wants a patient on hospice, we will ask, geared questions or steered questions where, has the patient lost any weight? Have they had multiple falls? Have they had any trips to the ER? What's their overall decline? Now you can tell us that because we have a business associate agreement with you, so you can tell us that, but we can't share all that information until the family says it's okay. If you get something signed in your paperwork that says it's okay for you to send information to a outside or third-party vendor, then you can do that. But otherwise, you can't do that without patient consent. So long-term care, we provide educational material for you to hand out to the families. Usually that's like in your social services or your admissions. Even that varies. That may be the same person, that may be two different people. You guys decide how that's done in your building. Hospice doesn't decide that. So you guys decide who's your point person. It might be the DON, it might be the ADON, it might be the MDS coordinator, it might be whoever y'all decide who does that. Okay, let's see. So provide hospice documentation, we talked about that. Evaluate the needs for MDS reassessment. So if a patient goes on to hospice services, the MDS is required to do a significant change MDS. So we do have a great relationship with our MDS coordinators, because anytime anything happens, we communicate that to the MDS coordinator so she can submit that, or she or he. So let's say that the patient signed on to hospice. Well, the MDS coordinator has to send a significant change. Now let's say the patient has now a new wound. Well, she's got to do another significant. So those kind of things, we keep you guys updated, and your MDS coordinator updated on anything that's going on with that patient. We know you guys keep them updated as well, but we think that's our responsibility as well, because we know you have to submit those things.
Some facilities have a form that they have us fill out. Some, so that they have certain hot questions or whatever. And so every time the nurse goes in to see your resident, they complete this form before they leave the building, and then they turn it into you guys so that you have a hard copy record of what's going on. Did they have any new wounds, like Keisha mentioned? Have they, whatever's going on with them, you have that, to be able to care plan that or do whatever, instead of just a verbal. If you have 70 residents and one MDS coordinator that's running, and you grab her, oh, hey, Susie, I just want to tell you, Miss Jones has a new wound on, okay, see ya. She's got, a million other things that she's doing, and it might be forgotten. And so we never want that to be an issue either. We want to make sure that communication happens appropriately so that everybody gets the information that they need. So that's why I think the form is a pain to do, but it's also good because then you have the proof of what has actually changed.
So I think we've covered all of this. So once we do an assessment on a patient, decide that they are eligible for services, at that point, we need to let you guys know that we picked the patient up, what diagnosis we're going to pick the patient up under, and what equipment and supplies and meds that we are going to cover. You should get a form. Well, we provide a form to you that tells you all the meds that are covered. We provide that to the family as well. And then whatever DME equipment. Some facilities want us to bring our own DME equipment, meaning hospital bed, wheelchair, over the bed table. Want us to bring all that in. Some facilities do not, because they don't have storage for those beds outside of there. So, or they want, of course, like during COVID, they don't allow us to bring any equipment in. So you guys use your own equipment, but that is something that we need to let you guys know what we're going to provide.
And sometimes I just need like a specialty mattress, so maybe it's a low air loss mattress. We can do that. Use the bed frame that's there. Sometimes storing a mattress is easier than storing the whole bed. So there's little ways to do it.
Okay, so we talked about the contract already, so we're going to move on from that. Okay, so integrated care planning. Again, care planning is like a hot topic for surveyors in your place and in ours. So a lot of times you can get around a regulation. Let's say, I'll give you a for instance, like we had an ALS patient one time or a Huntington's chorea patient, sorry, not an ALS patient. We had a Huntington's chorea patient that just, if you've ever seen that disease, they're just spastic, jerking, their whole body just jerks. Typically they can't sit in a chair, like couldn't sit here by the time they're on hospice. They're just too spastic. So Now, she was always in the floor. She was always falling out. So we care planned that she didn't have a bed at all. So we did ball mats all over her entire floor, and she just was on the floor. But we had to care plan that because that's certainly a dignity issue for you guys. It's certainly not something that we want to happen, but it was for her own safety. She had a private room. She had no roommate. She had fallen so much and had so many breaks from like a bedside table, or she would fall and hit things, and just it was just awful. So it took the hospice and the long-term care to care plan her to be able to be on the floor, because she was so spastic, and it was almost like a fish out of water. You've never seen that diagnosis. It usually happens to very young people, and it's hereditary, and that disease is just awful. It's just awful. And they just look like they're just flopping all over the place. And so we had to have her in a helmet. We had to have bumper pads all around the walls so she wouldn't, because she kept hitting the walls. I mean, it was hard for us to figure out a way for her to be safe. But
Lots of care planning.
oh my gosh,
helmet
yes,
for the room.
helmet, the floor,
Yeah.
yes, tons and tons of care planning. So, but it took us to collaborate with you guys to know what your rules were, what we were allowed to do. And listen, at first, the nursing home did not want to do it. The long-term care, they did not want to do it. But the more we got the ombudsman involved, and then that patient stopped having all of those injuries. And she ended up obviously passing, but that took a lot of collaboration on our part with your regulations and our regulations and the ombudsman to be an advocate for the patient. So that was an example I can give you of having to override your regulations for the patient's safety. So that's what had to happen. And when in her early stages of her disease, they weren't allowing Mary walkers anymore for a long time because she couldn't open it. So they called it a restraint, but we were able to care plan that and able to let her use that in her early stages of Huntington's. And then, so that facility was fantastic about working with us to try to, and we met the patient's needs. And unfortunately, we had to, be a hard patient advocate because she just kept going back and forth to the hospital all the time, and that's not quality of life. So it ended up working out really, really well. So you can see how we can help. Yeah, how we can help with that, because we provided all those fall mats, we provided the helmet, we provided all of that. We did the verbiage for the care plan, and so we were really helpful with that situation.
So then obviously the care plan changed through the course of
Oh, yeah.
of her care and her
Almost monthly, yeah.
Yeah. As her symptoms changed, then the care plans have to change. Maybe she became bedbound and she didn't need whatever. We were able to.
Right. And it wasn't until the end of her, probably the last 3 or 4 months that she was on the floor. And the facility really struggled with the dignity issue because, when people would walk by, she's laying on the floor and they're like, what is going on? So, but they really, really struggled. But after we care planned it and the patient quit getting hurt and they quit having to report to the state all of the falls, that really, solidified our relationship with that facility because it stopped all of their extra work as well. She was on the floor and that's okay. She's going to be on the floor.
Yeah.
So, okay. Let's see. I just covered all of that. I think we've covered all that. I'm moving on because I think we ended 11:15 and Tom still has to go over advanced directive and do not resuscitate. I think I told you all of those things.
But that's a good point, where she was just talking about let us help you. You have hard residents and hard situations. We want to be a resource to our long-term care partners because there are some things that we can help you deal with that are just out of control on your side of it because of all of your regulations. Let us help you do, if they can qualify to come on hospice, let them use that benefit of hospice and let us help you, keep them there. It helps you, you get to keep that resident in their home and they don't have to be bouncing around. And so it's a good collaboration.
So I am going to say something to you that it typically makes long-term care administrators uncomfortable, but it is our regulation and it is yours. the hospice assumes case management of the hospice patient. So meaning that you guys are going to provide the custodial care, but every other thing that happens with that patient has to be approved by the hospice. And Medicare says that that's the way it goes because we're billing Medicare first, and they need to make sure they are paying us. So they don't want to pay another entity to do something else that we should have done. So they put all the responsibility back on the hospice to say you're required to provide every single thing for that patient for that diagnosis. So you are ultimately responsible now over the nursing home. So that being said, a lot of times when we have these kind of conversations with long-term care administrators, they're like, well, they're our resident. You're right. They do live here, but Medicare is paying for their service for hospice. So now Medicare says that the hospice overtakes their care, meaning that we are responsible and we have the last approval for whatever is going to happen with that patient. So that's very different than home health. That's very different than Advantage. It's very different than anybody else that's going to come into your building. So that's why it's so important to have a way to flag those hospice patients in your building. If they, don't send them in and out to the hospital all the time, because what ends up happening is we've told the family when we sign them up on service that the nursing home is going to call us. We are the ER. We're going to come to the patient. We're going to try to treat the patient where they are. Medicare doesn't want them going to the hospital anymore. That's the whole reason that this is a paid benefit now, is so they can eliminate that hospital stay that Medicare has to pay for, or that ambulance trip that Medicare has to pay for. So they are paying us to come manage those symptoms where they are. So if a patient has fallen and they have a clear break, you can clearly see that there's a break. Obviously, we're going to send that patient to the hospital. But let's say the patient is agitated or combative or something like that in your facility, and say it's 3 o'clock in the morning, and your night nurse doesn't have my PRN medicine because your pharmacy DC'd it. and you guys are a lot less staff on that shift, right? So in our heads, you would just call and let the hospice come deal with it, right? But what ends up happening is there's not, especially since we went to electronic medical records in long-term care, there's not a great way to flag that patient as a hospice patient. It's not huge, it's not purple, it's not big. Before, when we had paper charts, you'd open up that chart, and in the very front page, it would say stop, a big red stop sign that says this is a hospice patient, call hospice first. So that has changed now. There's no way for us to put that big old piece of paper in your electronic medical records. So sometimes the night nurse, and especially during COVID, when you guys are having to use agency a lot, they don't know those people, and so they'll have an issue and they'll just send them out. Well, then you've got upset families. You've got a patient that didn't need to go to the ER. We could have handled it right there. So now we've got Medicare paying for transportation. You've got an ER visit, and the patient is still suffering because they had to sit in the ER for 14 hours until they got a shot of Ativan. So it's not in the patient's best interest. So I use that example because it happens every single day. Our patient will get sent to the hospital, and it's worse because agency people don't know who they are. So we've tried to collaborate with nursing homes to come up with a way to recognize a hospice patient. At one point, we were going to do wristbands, I think, a certain color of wristbands, and we were going to collaborate with all the hospices and purchase these wristbands, and everybody gets a wristband if they're on hospice. But I don't know what happened to that. We used to do that with patients that were a fall risk or a DNR. We used to do that, but they don't. Okay. All right. Hospices are required to attend your care plan meetings. So make sure that you're sending out those letters. Whoever is responsible for that, make sure you're calling the hospice, faxing them to the hospice, and letting us know. A lot of our team, particularly in my company, they will, the social worker will be there, the nurse will be there, sometimes the chaplain will be there. So a lot of our representatives are going to kind of be there to be in that care plan meeting, especially if we have some issues happening. If there's some issues going on where the family's really unhappy, or the patient needs more care than they're, like, especially like in a long assisted living. Let's say the patient's declined far enough to need more care, but the family really can't afford more care. So what are we going to do? So we really need to be involved in all of your care planning. And if you've noticed in any of these slides, care planning is almost in every single word. So we definitely have to care plan what we're going to do with that level of care. So just include your hospice. Your hospice shouldn't be an irritant to you. They should be a compliment to you. They should take some of the burden off of you as far as work. We should be able to take some of that load off of you, and not, if your hospice is being an irritant to you. There's a lot of hospices, change hospices. So, all right. Clearly identify who's paid for what. So let's say the patient has fallen multiple times, and you guys are required to do so many interventions because of falls, and we know that, but therapy is not usually one of those interventions for falls for a hospice patient, depending on the diagnosis. Typically, a hospice patient shouldn't be able to participate in therapy. They should be sick enough to not be able to do that, depending on what the diagnosis is. Sometimes they can. Sometimes hospice will approve therapy for, let's say a patient's going to be going home from your facility. Let's say they were skilled, and now they're going to go home. So they go home. They have now we need to teach the family how to transport them or move them or whatever. So we might have therapy come in, or occupational therapy come in to educate the family on that, but not necessarily for strengthening for a patient. Yeah, not for rehab purposes. Again, yeah, I agree. So hospice is responsible to all parties for coordinating, communicating, and ensure proper documentation of all terminal illness orders. So anything that we order for a hospice patient, or you do, we're required to coordinate all of that. So a lot of times, like I said, they won't know it's a hospice patient. A nurse practitioner will be in doing rounds, and they'll write orders for whatever. And then the nurse will just do what she does. She'll send it over to the pharmacy, and the pharmacy will fill it. Well, it should have been covered by hospice. So then we have to end up either backing it out of their insurance and pay. So it's just a mess. So there needs to be a better way to identify hospice patients. So just when you are out there and teaching your staff, you need to come up with a way, or however you guys are doing it, so everybody is aware that that patient is a hospice patient. And we get in trouble from OIG if we don't pay for medications that are related. So we're governed by OIG. I mean, you guys are too, OIG, and we are also governed by an accreditation body, which is, I don't know, y'all probably all heard the term JCO, things like that. Well, we use something, we could use JCO, but we use something called CHAP, which is a community health. So that's where we fall under community health. So we are an accredited body. And so those standards are just higher than Medicare standards. So we have to abide by higher standards than just a traditional hospice that is just Medicare certified.
You only pay for the medications that are related to your diagnosis.
Correct. Yes. So let's say that a patient has dementia, and they also have heart disease, but that's not necessarily related to their dementia. Then the heart medication would be covered under their, Medicare Advantage, Medicare D plan or whatever. And then let's say their dementia medications would be covered under the hospice. So they may get their medications from two different pharmacies. That's why the hospice is required to provide you and the family with a list of meds we will cover. So everybody's on the same page. Again, when we went electronic medical records in long-term care, it definitely made things harder for the hospice and harder for the, it shouldn't have, but it did. it made things harder. Point-click care is what a lot of people use, and there's just like one little word that says hospice. It's so tiny, there's no way to flag that patient. Okay. Obviously, you're going to get all orders. You're going to get all the orders that we get. You'll get them signed. A lot of times the facilities want the signed order before they'll put it on the MAR. Well, we can't get it signed right away, neither can y'all. So I don't know why that's possible, but I've run into that. You know, when you guys take an order, let's say your nurse takes an order over the phone, and it mainly happens in assisted livings, actually, because there's not a nurse in the building. A lot of times there's not a nurse in the building at 4 o'clock in the morning. It's a mid-aid or whatever. So like, let's say I ordered this one. Again, I'll go back to discharging of medications that we need. So assisted living, they DC'd our Ativan, and now I'm out there at 4 o'clock in the morning with an angry patient in a memory care. And even if I got the med-aid can't even put it on the MAR. So I don't know how to fix that. So if you hadn't DC'd my medicine, then the med-aid could have given it. I still would have come, but the med-aid could have given it. So that's some challenges that we come across sometimes, and especially in assisted living where there's not a nurse on duty 24 hours a day. So that's definitely challenging sometimes. Okay. Orders. This is what we talked about, IET and long-term care. You know, coordinating those care plan meetings and developing that care plan. And we should establish what equipment you're allowed to have in your building. And again, with assisted livings aren't allowed to have bed rails. They can have positioning rails, some of them, but they cannot have bed rails. And that's up to the facility and their regulations. So it's great for you guys to, when you have a new provider, make sure they understand what they are. It would be awesome if the facilities would have these are not allowed here list, or you know what I mean, you cannot do this here, because every facility is so different. Like one assisted living will let you have a whole bottle of Roxanol, which is like a 30 ml bottle of Roxanol. But then another assisted living says, nope, that's got to be drawn up in pre-filled syringes. So it would be great if we just had a piece of paper that would know that, because we don't want to make you mad. You know, we want to do it the way you want it done or the way you require it done. And we understand that you guys have put rules in place for old deficiencies or for a best practice, what works best in your facility. So, but that's different everywhere. And as an administrator changed, so do their rules. So it'd be great if you had your own like list of no's or list of yeses in your buildings, and to hand to those vendors and those providers to take the guesswork out of it completely.
Because again, we just want to provide the care for the patients. And
yeah, we're not trying to make y'all mad. We're really not. So the more information that we have would be better to, you know, to have. So, all right, clinical records in accordance with you know, confidentiality, written authorization. I talked about that already. Written authorization to share information. Oh. Medical records, you are required to get all of our notes. You're required to get all of our aide notes, our chaplain notes, our social worker notes, our nurses notes, our care plans, our certifications. And so your hospice should be providing you either one, login and access to their medical records for their patients. They can do that. They don't have to provide them in paper. They can provide them like that. They can provide them in paper. And a lot of hospices, nursing homes don't want to log in and get your stuff. They don't want any more work. And I get it. There's a lot they have to do in a short amount of time. So a lot of hospices will have hospice books in their buildings, and then they will bring their own stuff and file their own stuff, and it should be right there for you. Very rarely do you guys look for it until survey is there. When survey is there, you're looking for it. So if you guys are in your survey window, I would be saying to your hospice, check your books and make sure your stuff is in there, because you can get a deficiency if our stuff isn't there because we didn't coordinate care. So that's how we show coordination of care too, is that we give you the notes and the care plans and all that stuff. So just make sure that if you're in your survey window, or make sure that you have a clear process of how that hospice is getting you that information, because I've had hospices people will call and say, I need all your notes, like, I don't know where they are, can't find them, blah, blah, blah. Like, we'll print them and run them to you or fax them, what do you need? So we'll get them to you as soon as you, what do you need? So, but if we already know that you're in your survey window, our people are taught, my staff is taught to check those books every time they're in there. Every single time they're in there, check those books, make sure they're filing those things, and my entire staff files things. So if you're only letting my nurse in your building because of COVID right now, then the nurse will file. But if you're letting other people, it might be the aide, it might be the social worker, it might be whoever. Ancillary therapies, tube feedings, physical therapy, occupational therapy. That will be something that you will need to coordinate with your hospice. It will be based on their policies if they're going to cover tube feedings. And I use this example in this class every time. Tube feedings are nutrition. If a patient is in your building, and let's say you have a patient that's not on hospice and they're on Medicaid, and you get paid room and board for that patient, that means you're required to pay for their food, right? And you pay for their living. Some hospices do not cover artificial nutrition or hydration at all. They don't feel like it's palliative. They feel like it's life-sustaining treatment. Also, they don't pay for it because a lot of companies don't pay for it because they don't, let's say they have 2 patients in your building and one had a stroke, or let's say one is just quit eating and now the family wants a pig tube. That's number one. Let's say you have another patient in your building that has the same diagnosis and they're both Medicaid, and you're getting paid from Medicaid to pay for their room and board. So the hospice may elect not to pay for tube feeding because you should be paying for their food, not the hospice. Or they've elected that it is not palliative, that is prolonging life. So if that disease followed its normal progression, that patient would not eat. So, and they would pass. So that's up to the patient, the hospice, and you guys and the doctors. That's how that all works. Every hospice is different. Every hospice philosophy is different. So you really need to get to the bottom of what they're going to pay for. They are required to offer physical, occupational, and speech therapy if it relates to that primary diagnosis. So let's say that that patient has heart disease and they fall and break a hip. At that point, they can actually stay on your service, stay in your building, and you can actually put them on skill, and they can still get hospice services for their heart disease and you can get paid for Medicare for their break for physical therapy. That has nothing to do with hospice, unless they had a syncopal episode because he had a rhythm that was messed up, or, that would have to be looked at. But there are situations, it's rare, there are situations where they can get both services. Nursing homes don't like to do it because they have to deal with the modifier, and most people don't know how to do that. But if the patient wants that and they push that hard enough, they can have it. It is their right. So we would just have to coordinate clearly what was covered and what wasn't, and document that very, very clearly. So that is an option for you guys as well, for the patient to continue to get those services, the hospice services and the skilled services or therapy services. But let's say the patient, patients have multiple falls, and let's say they're on a memory care unit or a locked unit and they have dementia and they're having multiple falls. And part of your care planning is to try an intervention of therapy. We're going to probably fight that. And because the patient is dementia, how are they going to cooperate with therapy? They're not going to be able to learn that. We understand it's an intervention that you need to try, but we're not going to cover it. We're not going to approve it. So it's going to have to be covered by the family or you guys. So most generally, we're not going to cover it on the dementia patient. They shouldn't be able to follow direction to have therapy.
So again, go back to care planning, make sure the care planning is correctly done, so that it says, well, hospice is involved and blah, 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 so.
Yeah. Yep. All right. So ancillary services may be purchased through you guys. So we don't have physical therapists on staff. Most hospices don't. Most hospices contract that out. If they're a hospice and home health combined companies, sometimes they might have that, but most hospices just contract that out. So let's say that you already have a contract with a therapy company and you want us to use that therapy company, we'd be happy to contract with them. We don't care who it is. So we just need a contact and we'll work those out. So we just need to be purchased. Sometimes even long-term care own their own therapy company. So we can contract that out with you guys and not have to bring another third-party person into your facility. So now it is up to the hospice if we can get that pricing at what we need. So we only are paid so much money, just like you guys, to take care of patients. So we have to make sure we can get a good price for that. So what we usually do is pay Medicare allowable. So if it's a Medicare allowable, whatever they were billing Medicare for an eval or for a therapy appointment, that's what we would typically pay. Actually, let's talk about one more thing in your contract. So we're going to talk about levels of care. Ooh, running out of time. Actually, I'm going to keep going. Bereavement, we talked about bereavement services, that we follow that family for a while. Oops, I missed one. Care plans. This is all just care planning. And you all have this PowerPoint, right?
I'm pretty sure. I missed it. I didn't get it printed out. I missed it.
It's long and long.
Yeah, you're like,
It's
oh.
not long.
Right. Okay. Okay, so let's talk about time of death. So when a patient passes, at that point, if we're not already there, then you would call us and we will handle it all from that point. We will call the funeral home, call the medical examiner, call the family. We'll handle all of that. And you guys will just, take care of the other 140 patients you have. So we got it. So you guys' responsibility is to notify us if there's a change in condition, and then we will come and be with that patient and then kind of help through the end of care. Something that a lot of nursing homes do that I absolutely love is when a patient is passing, they'll either have a room that they can put that patient in, or they'll have them in a private room where the family can come be with them. And then I love when nursing homes will bring down like a tray of coffee or tea or something like that for the family to be with that patient. So that's kind of stuff that you can oversee and make that happen in your buildings. And it's always great to have some sort of, I understand that this is the end for you guys, and we're going to make it as easy and as comfortable for you. So we're going to do our part, but that part for you guys, we're going to change them. We're going to do all that kind of stuff. So your part would be just to try and provide some refreshments if possible, and a place where they can, maybe you have a chapel that they can be in, or a private room or something where they can have some alone time. A lot of times facilities will ask the other roommate to move for a little bit so the patient doesn't have to be moved. But if the patient's passing and you have a room, if you have a spare room, it's really great. I've seen so many great things in nursing homes where they have, when a patient passes, I've seen it a whole bunch of different ways. When a patient passes, they will shut all the residents' doors and not let them see them leave and all this stuff. And then I've seen where they have all the residents sitting outside and they take them all through the whole place, that, yeah, you get to say goodbye, because that happens a lot where they have these patients that they got to know and spent a lot of time with, and then they don't go to the funerals. Those patients, very rarely do the people who live in that facility get to go to the funeral. So your hospice should be offering, a memorial or a funeral or a support to your residents, because not only they were part of their family, and especially if it's a resident that lived there for 20 years or 10 years or whatever, that's an integral part. And the whole staff can't go to the funeral. So we would bring that into you at the facility and honor that person. And so if that's something that you want your hospice to do, just ask them, and their chaplain should do that for you guys. And you can set that up to be, monthly, you can set it up to be quarterly, or just as needed, as you lose people, you can do it like that. So it's a good thing for your hospice to do, to be able to have those residents, especially like I've had residents pass that were on resident council. It was a very, very big part of resident council. So, I mean, everybody's going to pass. So those people were very active in that facility. And so there's loss there, and people need to be able to grieve that loss. So to have your hospice come on and take that off of you, it's another thing that you can promote, that you add value to their lives. You know, we didn't forget about them. This is what we do. And so you can institute those programs in your building anytime you want, and use your third-party vendors to do that for you. At the time of the death, the long-term care facility will destroy all the medications. We will not destroy or take any medications out of the long-term care facility. We will bring them to you, but we don't take anything out. And we follow your protocol. So if you have a certain way that the death has to be done, then you just let us know. We'll do it that way. Or your paperwork needs to be done. Okay, I just covered all that. I've done this a lot. So, you know, I already touched on the hospitalization. You know, please try not to send your patient to the hospital unless it is an absolute emergency, a hospice patient. I mean, if they're bleeding profusely and they've got a bone sticking out, we probably need to go to the hospital. But if it's a changing condition that's going to require just some medication or something like that, we really need to just kind of treat that right there. And so just make sure before all of your patients are going to the hospital that you have some system in place in your building to check if they're a hospice patient, because there's nothing worse than a 4 o'clock phone call from a family that is just irate that the patient got sent to the hospital again. So, you know, then they're mad at us and there's nothing we can do. And then they're mad at you and now we're trying to fix it. And so if we could have a way to, you know, coordinate that, that would be great. So you see this where it says the hospice may continue to manage treatment of the terminally ill patient while in the hospital and work to ensure the patient returns to symptoms control. So we have 4 levels of care in hospice, and one of those are GIP, so it's general inpatient. So let's say that your patient or your resident is just in pain, and we get there, we can't get their pain under control. We just can't. I mean, we've thrown everything at it that I can throw at it in your facility. So let's say that you won't allow me to put in a sub-Q pump, a morphine pump. That's against your rules. So I can't do that in your facility, or I can't put a PICC line in, or I can't do that in your facility. So I can't put a PICC line in anyway, but I'm just saying.
We can get it done.
Right, I get it done. But if there's something that patient needs that I can't do in your facility, then I have contracts at different places to move that patient into GIP. They don't come off hospice services. They're just going to move out of your facility for a little bit until I can get those symptoms under control. And then once those symptoms are under control, they move back to your facility. So that's when coordination is going to definitely happen between us, because we have to make sure that if that patient comes back, that we're going to follow what you're allowing in your building. I mean, for instance, it could be a sub-Q pump, and you're like, I'm uncomfortable with that. Or let's say they have uncontrolled nausea and vomiting, and the only way for me to control that is with an NG tube. You will not allow NG tubes in your facility, so they may not be able to come back to you at that point. So that's going to be a conversation that's why it's so good for you to have great communication with your hospice, because sometimes that happens where I can't control it with a pill or a gel or a patch. Sometimes I'm going to have to do it with an inhaler or, you know, nebulized morphine or whatever I might need that I can't do there or y'all won't allow. So just be mindful of that we're not trying to move your people out of your place. Everybody thinks that we're trying to move people out of your place. We are not. We want them all to stay right where they are. They're getting great care. We want them to live there. So we don't want to move people, but sometimes it may have to happen, and we're going to coordinate that with you guys. And hopefully, if they go to the hospital, we cannot do respite in your building unless you have an RN on staff 24 hours a day, and most nursing homes don't. And I think there's a couple other regulations, but for sure, you have to have an RN on staff 4 hours. Okay, so actually I'm gonna stop talking for a little bit and I'm gonna let Tom talk to you about the advanced directive and the DNR. And you guys have this slideshow and I'm gonna keep flipping through it a little bit as he talks, so don't pay attention to the screen, just pay attention to Tom.
Yeah, that's easier said than done. So, one thing real quick about the levels of care, we are required for a home patient to offer them respite care. And so that means a home patient, the family is exhausted, they need a break because they're primary care for this patient. So we would contract with the facility and say, hey, we have this home patient that wants to do respite care for up to 5 days. And so we move the patient to your facility for up to 5 days. We pay for the transport for them to get there. They're there. Our staff comes in and sees them while they're there. Meds are there, equipment, whatever the patient needs. Then at the end of that 5 days, then the patient goes back home. The benefits to long-term care is that this is almost a try it before you buy it type of thing. If this could be a potential where the family and the patient likes it there and they decide to go ahead and just leave the patient there. And then at that point, then you guys admit them to your, to a resident, and then we continue hospice services right along with how we were doing it. Sometimes they leave and then they do come back. And so that's a great benefit to the patient's family and the facility because, again, they get to kind of fill it out and see how they're going to do. And, okay, so I just wanted to mention that.
Moving on.
Yeah, stick to my topic.
Yep.
So we wanted to talk about advanced directives and DNRs because this gets very confusing and a lot of people get these confused. So the advanced directive is it's kind of like our wishes. Each of us should have an advanced directive, and it is a list of our choices and our wishes for what we want for our healthcare, really. And so there's 4 pages, and it goes through if we want to be kept on life support, if we want to have tube feedings placed, if we want to, all of those types of things. And so if we are in a car accident, these are sometimes unexpected events. You have a massive stroke or a heart attack or something that incapacitates you. These are my wishes. And so this allows you, like I said, to spell it all out for your primary care physician and for all other healthcare physicians to follow. And so there's also a spot on here to do a narrative so that, if you feel like that this isn't enough information, then you can actually write it out what you do or don't want. And so that you're able to, like I said, just, give your wishes. And so for your residents, and it's the same thing. If your resident is able to make these decisions, then these decisions could be made by them. If not, then their family could help make these. But this also allows the person to appoint a healthcare proxy. So in the event that the person is no longer able to make decisions, then this would be the person that I would want to make these decisions for me. And then you can have an alternate also. So that's also nice to do. On here, it actually gives you the right to for anatomical gifts. So if you want, you can choose lungs, pancreas, kidney, whatever body organ that you want to donate. You have that ability to choose that on here as well. And so this is signed and witnessed and notarized. And it's not notarized, it's just witnessed. And the witnesses of the advanced directive cannot be anybody that you're related to or that the resident is related to. It has to be someone that could not benefit from their death. So if you have like an insurance policy, that can't be their beneficiary. And so, so this just gives us all the right to be able to say, this is what I would want to do or don't do. You know, don't keep me on forever.
The biggest thing about this is this has nothing to do with their finances.
Right.
Nothing. So that's a whole different thing. So this is just saying that they can make healthcare decisions, not financial decisions.
Because that, yeah, that's a whole other, obviously, a whole other deal. And so, then on the DNR is more for hospice type patients. You know, if you have a terminal diagnosis, don't do CPR on me. I don't want you to bring me back. If it's my time to go, I want you to, you know, this gives us all in healthcare that permission to not have to do CPR, obviously. And so when a patient comes on hospice, we discuss both of these with them, but it is not a requirement for humanity hospice. They do not have to sign a DNR to come on service. We do talk to them about it initially, and then our social worker follows up with them and the family to, you know, discuss it with them and try to get them to sign it when we can do that. Sometimes we need to push a little bit more than others. There's some times where we do the initial paperwork and the patient's in bad shape. And so we will, again, going back to being honest with them, we want them to understand that we're going to need them to sign this sooner rather than later. Because if we don't, then they're going to have to be sent out to the hospital, or we're going to have to do CPR. And then we go through the graphics sometimes of we could potentially break a rib, puncture a lung, and put them through unnecessary pain that they may not want to go through. And so this definitely allows them to have that choice that say, do not do that to me. If it's my time to go, if my heart stops, I stop breathing, then let me go. Do not bring me back. So both the advanced directive and the DNR, they are both, we are able, the person is able to revoke them. So they're not necessarily stuck. But so this one is called the golden rod because of the color of it. And so the hospital has one, but this is the one that we use.
The state provides
The state provides this one, right? And so we like it because of the color. Obviously, it's easy to see. If this is in your chart, you're going to be able to see it really quickly and say, yes, that it's there. And so when we have a patient that comes on service and they sign one of these, maybe that's one of the reasons you want us to help with, and we will do that. And so then we obviously will provide you guys a copy of this for your chart and make sure that we communicate that with you that yes, they signed this DNR. And so we explain to them that they can revoke, they can still receive oxygen, and if they are eating something and they are aspirating or choking, then we're going to still be required to do the Heimlich maneuver. This was something accidental that happened and not something that was in, you know, part of their disease process. And so we let them, you know that that those things would still happen. They can still receive health, you know, health measures, like I said, oxygen. The rule changed on the DNR where the patient can sign it, or anybody in their family can sign it for them.
Or friend.
Or a friend or a close, you know, a neighbor or a close friend can sign this. If they have a relationship with this patient or the resident, and they know that this is in their best interest and this is what they would want, then they can sign it for them. And then you have to still have two family related witnesses that witness the DNR. Also on the back of this one, there's a place where the physician can sign the DNR. So maybe there's no friends or family there, the patient is incapacitated, there's no advance directive, and then the physician can say, based on, you know, my expertise, I am saying that this patient should be a DNR. And so that's sometimes an option that we have to use. And then that way we can allow the patient to pass away peacefully, and we don't have to send them, through all of this. And so most of the time, if I'm having this conversation with a patient and a family, I will tell the patient that this is a gift that you can give to your family for you to make this decision so that they don't have to. Because we deal with it a lot in especially home setting where the family struggles really, really hard to make this decision because they don't know. I want to keep them here, and we're selfish and we want to keep our loved ones here, and they don't always want to make that decision. And so sometimes it comes down to the wire where the patient is actively dying and the family still doesn't quite ready yet. And so we've had it come down literally where the patient passes 15 minutes later or, very, very short amount of time later. And we've, been able to finally talk them through this, that, this is in their best interest. And so, but again, the advanced directive changes a little bit when hospice is involved because the Anatomical Gift Act is typically going to require that the patient either be on a ventilator or go on a ventilator until the organs can be harvested. And so that's not typically what we're set up to do in hospice. And so we're not going to send them to the hospital for them to be put on a ventilator to have their organs, harvested. They're going to just pass away. And so that is something that we talked about. The benefit of hospice needs to outweigh their need to want to do that. So, and a lot of times their organs are already failing anyway, and so they could potentially not be a candidate to donate at a certain point. And so if they've got a lot of cardiac, cardiopulmonary issues going on, then it's going to affect a lot of our organs, and especially towards the end of life where things are starting to shut down, blood's not being circulated correctly, and organs just aren't functioning right.
Okay, so the biggest thing that you need to remember about this form is these two forms are completely two different forms. So this form stands on its own and this side stands on its own. So if they don't have a legal representative and they don't have any family or whatever, this form can be signed by the physician. So it doesn't have to be both sides. So if the physician knows the patient's wishes, they can sign this in your facility and for hospice, and this side does not have to be signed. Okay, by the representative, yeah. Does anybody have any questions? We're about 4 minutes over, sorry. No questions? All right, thank you guys for having us. We'll see the next group.
Yeah.
If you have any questions, you can get them to Z and then he can let us know. Thank you.